Good evening, everyone, and welcome to Pull Up with Limbs and Things. My name is Dr. Chanel James, and I am the owner of Limbs and Things mobile and telehealth physical therapy practice. I serve aging adults in DC, in Maryland, and in Virginia. I help you move from I can't do something to I can. Tonight on Pull Up with Limbs and Things, as always, we want to confirm something you know, challenge something that you don't know, and give you an opportunity to share that information with someone else. Tonight we have Dr. Carmen Cox. She is a
Hello.
physical therapist and she's also a graduate of Alabama State University. And we are both PTs that have had some experience in outpatient physical therapy. My experience hasn't been that much, but in the realm of outpatient therapy, I've seen some seniors, but some need to know a little bit more about what outpatient therapy consists of. And so we invited Dr. Cox tonight to talk a little bit about that. So, welcome, Dr. Cox. How are you?
Hello. Hey everyone. How are you? I
We're
am
good.
Dr. Carmen Cox. I'm from Atlanta, Georgia. Like she said, I'm a graduate of Alabama State, and I currently work in the hospital outpatient setting at Emory Hospital, where I also serve as the lymphedema therapist as well.
Awesome. So tell us a little bit about outpatient physical therapy. I'll talk about it from outpatient, not in a hospital, and you can talk
Okay.
from a hospital setting.
Okay, so in the hospital setting, it's still outpatient. So it's you kind of get the same thing, but the lovely thing about it, we see one person at a time. So that's one thing you can expect from your traditional outpatient clinic, where you mostly, sometimes they'll see 2 to 4 patients at a time, and you won't get that one-on-one time that most people want. But with the hospital setting, at least for the two hospitals I worked at, we always had patients one on one. So whether it's an hour treatment, 45-minute treatments, or if it's specialty patients, hour and a half, regardless, I'm able to build that rapport with that patient, build a relationship, and have that one on one time with them. So that is, I feel like, very important for those individuals to be into I guess that hospital outpatient setting, because I know how people want that time, and say they want to feel like they're important. So I think having that one-on-one time with that therapist is very important. So that's one pro of coming to a outpatient a hospital setting at the outpatient. So that's one thing to know as far as for the hospital. Another thing is that, usually everybody that's in the outpatient setting, encourages each other. So I wouldn't, don't feel, I guess, intimidated,
Hmm.
being a geriatric or just having other elements going on. Everybody's there for a reason, and so usually our patients, especially if they're coming at the same time, now everybody's kind of getting to know each other. And it's like, you gonna make it, we gonna make it together. Everybody's kind of encouraging each other. So that's the positive environment to be around is really also a good thing to push people to do better and be better within with their lifestyle and just whatever they have going on. Um, I'll say also, being an outpatient is not home health. So, I know home health, we give homework as well, but you're there, you're able to go into their own, setting, in their environment.
Hmm.
Uh, so with them, with outpatient, they have to remember, you have to do stuff on your own. I'm not gonna be there with you when you leave here, or you might come here twice a week. Some people are one time a week, and so when I give you your home exercise program, I expect you to do it because I'm gonna know if you did it or not. Because I say, okay, show me your exercise. You're like, what? Which one? What? I said that tells me you didn't do your homework. So, but yeah, I feel like those are that's important to know. Like, you have to take matters in your own hand. And then also, like, my granddaddy, he always calls and tell me, he's not used. My granddad's 85, and he's not used to having anything wrong. Like, he's so into there. Him and my grandmother are very independent, doing everything themselves. And so now they'll have little small things going on, and they want it fixed quickly. Like, I give them exercise, I give them all these things, and they'll be like 2 or 3 days. Well, how long is it? How long am I supposed to let this go on? Like, when are you gonna come? Do you need to come over here? Like, how long do I do? I said, Granddaddy, like, you just got the exercise. You just got the exercises. So I would say be patient. It's not something that's a quick fix, especially if it's something that, if you're not used to having things going on. But even if you are, just understand that it's not going to be a quick fix. But if you notice changes, positive changes, like you said, well, it's not hurting all the time now. It's just intermittent. It just comes and goes. Mm-hmm. Granted, that's a good thing. That's, it's
getting better.
Is it supposed to do that? And, so I'm like, well, not saying it's supposed to do that, but I'm saying it's an improvement from where you started.
Right.
So, helping other people the geriatric population understand, it's not, and really that's what everybody, they think it's a quick fix, but, it just takes patience and time sometimes to get those things back in order. So you just have to give yourself grace, give the therapist grace as well, because you might be doing something and, just teaching them how to communicate with the therapist about, hey, what's working, what's not working. This caused more pain. This caused less pain. So we'll know if we need to change up the plan of care to best fit that patient needs.
Absolutely. That was great. A lot of times I think we don't know that even in a hospital setting, you could be working with multiple disciplines.
Mm-hmm.
And then in an outpatient setting that's not in a hospital, you mainly get a physical therapist, maybe a physical therapist assistant, and a tech. Right? So that's like another difference between the two. And then in a hospital setting, I feel that it's more accessible for anyone. Mm-hmm. There are ramps, and all these different ways that help get in easier, especially if you are unable to walk into the facility.
Right.
And it accommodates you because they're accommodating larger objects like gurneys and things to get in the doorways. Right. You have automatic doors. You don't always see that in outpatient facilities that are not attached to a hospital. So that's something to consider as well. Now, I have a question for you. So when a person is coming to an outpatient in a hospital, are they having to be already in that hospital setting to be referred to you?
No. So we can get referrals from anybody. It doesn't have to be in that hospital at all.
Okay. No. Good.
We have people that are, have nothing to do with Emory, was referred from their podiatrist or vascular surgeon or, or breast center or something like that. So no, they don't have to be associated with the hospital.
Okay. If you're watching that, go ahead. Go ahead.
Okay. So I did, when you talk about things being accessible, it just also reminded me of how good it is. I know being home health, if something happens or the patient is feeling, where you feel like you have to call 911 or if it's emergency, that is also the plus. Being in the hospital setting, we're able to call a code or whatever we think, and they're able to come straight down. Like they always have a team that can come down to our outpatient setting, which we had to do a couple times since I've been there, which is good to see. Like there, is it really basically called a rapid response. Mm-hmm. Whether the patient, blood pressure is too high or become unresponsive or whatever, or like we had one patient that had like we've gotten a lot of patients since one of the Shepherd. If you ever heard of Shepherd in Atlanta, they have like a waiting list. So we've gotten a lot of spinal cord injury patients. And so we had a patient that had a situation, they had to call a code or whatever, and he was fine, but they were, very quick to come and to respond. Whereas they were at home or, somewhere else, they could call 911, but it ain't gonna be that fast.
Exactly. So, that's a good caveat, I would say. Yeah. So for anyone who's a senior and you have multiple comorbidities or you have some concern that if you do exercise that you're also going to have some other physiological issues, maybe you should do outpatient at a hospital versus the outpatient that's not attached to one.
Mm-hmm. Yep, because they're still going to have to call 911 and wait just as if you were at home.
Right. Exactly. Okay. So tell me a little bit about some of the typical diagnoses that you see in your center. You talked about spinal cord injuries. Anything else?
Yeah, I would say most recently I'm getting a lot of like lumbar radiculopathy, like a lot of sciatica,
Mm-hmm.
a lot of neck pain. You just usually would have like neck, doctors don't write full, they just say neck pain. There's no specific no specific thing, just neck pain.
Mm-hmm.
I'm trying to think. I just
Joint replacements. Are you seeing any of those?
anyway.
Or joint replacements, knee pain?
Oh yes, okay. So we get a lot of so yes, I've got my one patient, I really love her. She actually had to get her surgery again because of COVID. She didn't get to see her doctor or something. They didn't want her to come in. Well, her whole incision had keloid. Like it was huge, and they had to redo
Great. Yeah.
everything. But she's doing really good. So we do get knee replacements. I haven't had a hip replacement in a minute, but definitely shoulder, so rotator cuff injuries. I've been getting a couple of those. So like a lot of people they'll get one surgery and then like I think she's like maybe 14 weeks out now and she's about to get the other one. So some people get them back to back. And I'm like, this one not done. She's like, I gotta get it done before the school year start because I can't wait. I gotta get my whole check. So I was just like, gotta go while school out.
Yeah.
To go ahead and get it. Yeah, so it's funny. But yes, I'll say rotator.
I think I heard you say rotator cuff. You still there? While Dr. Cox is coming back. If you're watching us, please hashtag live in the comments. If you're catching this on a replay, hashtag replay. If you have a question or a comment you want to ask, please put it in the chat as well. You back with us?
Yeah, both your screen and my screen, it just started low.
We froze for a moment.
I thought we were both off, but yeah, no, both screens just went black.
Okay. I didn't see that on my end, but I hope all is good now. Okay. Brandon says, what's the strangest diagnosis in the hospital that you've seen?
In the hospital or in outpatient?
Outpatient hospital.
In the hospital. Usually the diagnosis would
Seems like you're still thinking. You there? Say it again.
I'm here. Can you hear me?
Yes.
Okay. I didn't treat this patient, and I can be honest, I can't remember the specific diagnosis, but I can tell you the symptoms and everything that they had. But basically, this patient had COVID, and this was a result of COVID. Afterwards, like it's almost like he had a complete spinal cord injury, like after COVID. Yes, and then so literally can't move his arms, legs, anything. In a wheelchair, he was in a power wheelchair, and I just watched him. He working with him. I mean, it was hard for him to even, to transfer. So they're teaching him how to use a sliding board. Can't walk. I mean, this person worked in the school system, was independent, and then got hospitalized in the hospital and had this, because of, this weird. They've been seeing a couple of these, and I know of like they just these almost coming up like spinal cord injuries after COVID, and so almost like not like a polyneuropathy, but it's just he was like, he requires total care now. So, but he is getting a lot better. I know they've been he was getting so much therapy. He got PT and OT, And now because his insurance, like, he's got so much therapy. It's like now, okay, he needs to pay out of pocket for, pay out. Yes, he's maxed out, and it's just like it's so sad when somebody really needs it. It's like because they were starting to get him to stand. He was in the standing frame, trying to take steps. It's like, dang, somebody who really needs, really continuous all the time, and he's the one that really wants to work hard,
right,
to do it. It was just like he couldn't. So I can't think of the exact, diagnosis that they gave him, but I'm gonna tell you that's really one weird to have, after, somebody who went from, has a family, independent, and then boom, gets COVID, and then has these different elements following. So,
very interesting. That's where LimbsNThings kind of picks up, because I know there are a lot of times where people, they'll not necessarily max out, but you've gone through the realm of being in a hospital setting, you've been possibly inpatient rehab, or you've gone to a skilled nursing facility, and now you're at home. You kind of figured out, oh, I'm done with all of those therapies, but I'm quite not at the level that I need to be at home. And so that's where we come in terms of mobile PT.
Okay.
And telehealth PT, trying to get the person to the highest level they can be in their home environment, because home health only takes you a certain distance.
Yeah.
And then you still need further therapy to, meet all of your goals.
Right, exactly. So it's really hard, and unfortunate that they was like, oh, they only give him like, I think it was like maybe 15 or 20, like 20 visits a year or something like that, and it's just like he comes see us 2 or 3 days out the week, and it's just like
20 visits gets run up in a month.
That stuff going quick. So I'll say I feel like that's one of the, I don't get too many. Like I said, usually they never put sometimes the exact diagnosis. Like it's something I've looked up in their history that shows, okay, I see that they have this. I know I've seen a lot of people who suffer from alcohol abuse that will have also like, you would think, like, oh my God, what's going on? They can't walk, they can't, and they're like young. When I mean, I'm talking about 30s, early 30s, and I'm like, did I miss something?
Right.
Oh no, this is me. As I'm, being in the field more, just noticing like, okay, people who are, have alcohol issues or are long-term drinkers. This is one of the, just long-term effects where they start, just basically not able to thrive. Trouble walking, can't walk, in a wheelchair, become independent, and very frail as well. So it's just like, oh, okay, I see.
Yep.
This can, be, and therapy was effective, but if they're doing the same thing, it's only so much you can do with therapy as well.
Right. And that's a good point to bring out as well, because I think a lot of people think physical therapists only look at your musculoskeletal system. Yeah. But we have to know a little bit about your personal history to know how these things are affecting your inside of your body, because all of those things tend to show on the outside of you.
Oh, yes.
So, yeah, that's a really good point. We have another question. What is the best achievement you've accomplished in physical therapy?
Let's see, the best achievement. I got a couple. First, let me thank God, Jesus, for passing the board exams.
Amen. Yes.
Yes, because that getting out of PT school.
That's just
because let me tell you, it was Jesus was on my side. No, but it was, but it was hard, because we had a lot of things going on that wasn't just PT related that I dealt with within my cohort. And so it was just that on top of trying to make sure I'm passing my classes and stuff as well. So you had that, and then again, passing the board exams, and then it was getting my, my first job. Then it was, I got certified in lymphedema. So that was a very big accomplishment for me because that took me so many places and put me, in front of people that I probably wouldn't probably usually be in. Like I started a lymphedema program when I was in Kentucky, and I was able to be in close contact with the oncologists and different doctors that I was really close with. And then started my business with my husband, Top Notch Physical Therapy. So that we started last year. So that was one of our other biggest accomplishments for PT.
That's awesome. Congratulations to both of you on that.
Thank you.
Yeah. So let's talk a little bit about any barriers that a senior might have going to an outpatient therapy center.
Any barriers?
Think of like a wide range of seniors.
Right. I'm trying to think. Any barriers?
What do you have to be able to do? Like, I know we have high-low tables,
Right. Yeah, so we usually have high-low tables. So basically, I guess because being in a hospital setting, we have so many other resources that other people don't have that we can use if patients have other things going on. Like I said, this patient, usually most outpatient clinics won't take those type of those spinal cord injuries like that anyway. A lot of people don't.
The risk, right?
Huh?
The risk.
Right, the risk, and then just some people are just they're not able to do the one-on-one time with those clients. You can't have a spinal cord injury and then you got 3 other patients.
Right, and they take a little longer.
Oh yeah, they take more sweat too. I told my coworker who mostly works with most of all the spinal cord injuries, she's big on neuro. But I said she has to eat her breakfast in the morning. Like she gets a good sweat in for sure. But because she deals with a lot of spinal cord injuries, and so you're talking about people who don't have full body weight when you're trying to transfer them or move them. And with most clients, you can't. In other outpatient, you can't do that. So I would say, as far as barriers, I guess I haven't really seen to where I am as far as the outpatient clinic many barriers. Is there anything, I guess, particular that you were thinking of that they might have trouble with, and maybe I can speak on that?
It could be in that type of setting when you have to have someone else with you and needing more space, because there are a lot of times where you got this much space for the one person.
Right. So in that manner, we have a lot of patients who might have dementia, or they might need somebody to translate, or just even people who just want to be back there with a significant. They gotta be back there. And not just me. I'm like, all right, come on. You can sit, because just how our clinic is set up. I mean, it could be like little cubbies where I can space us off where we don't have to be with everybody else. So that's, I guess, the good part about our clinic. But we do allow people to bring their, one person with them if they need it. So that's a good thing about with them. So that wouldn't necessarily be a barrier for them. That would be a good thing. Where other clinics, they probably won't allow that, especially with the amount. We can have 5 or 6 therapists at a time working. So, you talk of all of our patients together, including, OT treats in that same room as well. So with their patients. But we also have, if I'm ever worried where it's too crowded, we also have individual rooms. So I was like, hey, if I ever need, like I had one client, her husband had dementia, and she had to bring him to therapy one day.
Yeah.
I know we talked about it before, and she was like, hey, if I ever have to bring him to therapy, does he have to sit out there, or would I be able to bring him back? I just would hate for him to be like, I don't know where I'm at, and then walk off.
Right.
I'm like, oh no, he'll be able to come back. I'll make sure if we have to go to a separate room or go to my lymphedema room or wherever, we'll be able to do what we need to do in the room. We don't have to be in the gym setting. But even if we did, it was still, it's still space where he could be out there if we needed.
That's a good point. So let's talk a little bit about you and lymphedema, and from the oncology aspect, though.
Okay.
So tell us a little bit about what lymphedema is and how, say, if a person has had breast cancer, what they can do and when they should see a physical therapist.
First, so lymphedema is most people think, oh, it's just, it's just water fluid. It's not. Lymphedema is, would you say, mostly fat. It has some water in it, but it is mostly like a fatty, milky fluid that's in your lymph vessels. And so anytime you have your lymph vessels damaged or lymph nodes removed, it also can be genetic. You can be born with it. Some people think, oh, I just had surgery or had, breast surgery, but you can also have the genetic code that you can be born with lymphedema as well. So that's why it's two types. It's a primary and secondary. So primary meaning you're born with it. You have some type of either your lymph vessels are too small or, or too large. And then also the secondary is where you've had some type of surgery or something's happened where that has caused you to have lymphedema. So as far as for oncology, for my breast cancer survivors and patients, I would say when I was in Kentucky, we had the program set up where I would see the patients before they have surgery.
Okay.
So they will get so of course they see the oncologist, they know their surgery date. They will come see me where they'll get all the education they can get. So the signs and symptoms of lymphedema, I'll give them a home exercise program. These are exercises you need to be doing after surgery. I will give them things that, like I said, things to look for. So things on their skin. So if it's red, hot, I'm looking for cellulitis. Make sure you don't have this. If you notice your clothes getting tighter, and that was about it. Yeah, and then just teaching them what lymphedema is, the different stages. I say, hey, you're in this stage, right? I mean, you're not in any stage right now, but after your surgery, you'll be in stage 0 because now that you're at risk of getting it after you had surgery, so they'll know what phase they're in. And then I will measure both of their arms. I had a machine called the Sozo machine, which I love. I don't have at this company, but basically it gave me the percentages of their lymph fluid within their whole body. So on each, it compared both arms, both legs, whatever one I wanted to do.
Okay.
And then based off when they come back, when we redo it, it'll let me know if it's increased or stayed the same. But if it's gone up a certain point, it'll tell me, okay, this patient needs to, I need to order them a sleeve. So this is research done with Medi USA. They do garments and sleeves. So basically, it's getting ahead of. It's showing me if this patient has swelling before they even see it.
Okay.
And so that's really helped with the breast cancer patients there because so they won't have to go into the wrapping and all that. All they had to do was if their number spiked up, I just put them in the sleeve. And then they will be in the sleeve for 4 weeks. They come back, I measure again. If it went down, they don't have to wear the sleeve. So it was really different. But I would say definitely go right after if you know your surgery date, go before, even if it's just one visit to get educated about it. I teach them about, their sleeves. But a lot of people, like I saw, even after their surgery, like 5 years later, and, that time period, like between 1 to 5 years, is when you can most likely get lymphedema.
Right.
So I had a lady whose arm was huge, like huge. And it was just like, she had so many other comorbidities and not enough help. That was that geriatric that was needed home. Like if I plan on starting trying to do lymphedema within the home setting with top-notch physical therapy. I feel like she did not need to come. When she did come to the clinic, she didn't need to be in the clinic. She didn't. I said, are you always having trouble breathing? Do you use oxygen? Asked me if she had her oxygen on. No, didn't have any oxygen. It's like 80 something. I'm like, where's the emergency? This is not gonna work. But so yes, but definitely before you want to get as much information as you can because you just want to get ahead of it. A lot of people say, oh, my doctor didn't tell me about that, or they didn't, they never informed me, or they didn't tell me I had lymph nodes removed, So I feel like it's very important because they're already going through so much, and this is something that can be prevented. It can be prevent as much as you can, when we have things out there now that can help.
Absolutely. Well, I thank you for bringing that out. So let's switch gears.
Okay.
The last thing I want to make sure that we give you an opportunity to talk about is your game. So if there are any seniors that have, or anyone who has a physical therapy student in your life, or someone who's interested in physical therapy, Dr. Cox, along with her husband, have created Physiotrivia. Talk about that.
Yeah, so me and my husband created a game. It's called Physiotrivia. So Physiotrivia is a game of knowledge and action. As physical therapists, we're very hands-on. We like to do stuff. We like to move. And so I was like, hey, this will be a great game for people in our field to help us study, to help even being in the, like I said, we're in the clinic with different, with OT, speech. This is a game that they can play as well. So building relationships, building bonds with your coworkers, building bonds with your, with your classmates as well. And so this is a game that can be used for that. So the game has 3 different cards. So we have this is what we call a physio card. And so it has a word on the front and then about 3 to 4 words at the bottom that you cannot say. But you have to get your team to guess this word here. So the word is tibiofemoral joint. You can say whatever you want to say, just not the words at the bottom. The team to guess this. And you can't point. Okay. If you use any type of action with this card, the point goes to the other team.
Okay.
Because this is a word card. You're only supposed to explain.
Okay.
Okay. Then you have tag team card. So basically with this one, it's only an action. You can't say anything. But when you get a tag team, you will show this card. You can pick anybody on your team. You show them the card and you guys act it out. So for this one, this is an anterior jaw test. For those who are in the physical therapy field, this is a special test. And so this, you show them the card. One of y'all get on the floor, whatever. You grab.
Straight.
Yep. And then your team has to guess anterior jaw test.
Okay.
That's the tag team. And then the next one is also we got action, but you do it yourself. It doesn't require another person.
Okay.
So this one is forehead. So I literally would be like, but I cannot say nothing like, when point goes to the other team. Don't even worry about it. Okay. So this is the acting out. So those are the 3 cards. Each team gets 1 minute rounds. So it has over 200 cards. So you could say, hey, we're going to do 5 rounds, or 3 rounds or whatever. Or the team who gets to 15 points first. But it's 1 minute rounds. And then, like I said, if you break any of the rules, usually the points go to the other team as well. And so that is Physiotrivia. So you can play this with like I said, with your coworkers, with your classmates. Even if you're, it's inspiring to be a physical therapist, this is a great game to already have, just to inspire you. Like, I need to know this, because it's a great study tool. I also, we took in consideration the board exam as well. So things that we probably usually wouldn't see, or I would say for me that I was like, I don't remember learning this in PT school, but when it came to the board exam, I was like, wait a minute. Okay, so I made sure I put some of those, threw some of those words in, because even though you think, oh man, that's hard, it was on the board exam, don't worry about it. Or in my board studying, when I saw it, it was just like, okay, this is very important. So it's very fun. Like other OTs can play as well. We plan on coming out with other variations of this game. So we'll have little cards, packets that will have like only cardio or only MSK or only intake. So then you can really break down if you like, okay, if you had studying for that day and you're working on intake, before you get started to hype yourself, hype you and your friends up or get y'all energized, y'all can pull out those cards and then also use that for things that you didn't know. You can write those down and make sure that you are comfortable and knowledgeable about.
Awesome. Very innovative. How can we purchase it? I'm waiting on mine. I'm so excited.
I know. Let me tell y'all, we are waiting for this game. The games was purchased in January. Okay. We've been waiting for a long time. So, but they said that they are at whatever, a port, vessel, whatever it is, whatever. It's just, they said shipping and stuff is crazy, but it's here in the United States. But whenever they said they take it off the ship, who knows? But we are waiting. But as soon as we get the game, it will be in everybody else's hands. Believe me, we will be making a big announcement when we see that update of that shipping. We will, let me get my stuff together. But everybody, y'all can purchase the game at www.PhysioTrivia.com, and that's PHYZIO trivia.com.
Awesome. Thank you all so much for watching, and thank you, Dr. Cox. I appreciate all that you shared about outpatient physical therapy, a little bit about lymphedema, as well as PhysioTrivia. It's always good to have a fellow alum here with us.
Yes.
And if you all are interested in connecting with Dr. Cox, if you live in the DeKalb County or Rockdale County, Georgia, please contact Top Notch Physical Therapy. Their email, you want to give that information?
Yeah, it's topnotchphysicaltherapy@gmail.com. And then you can also reach us at our phone number at 615-768-9690. And that if you have any questions or questions about our treatment sessions or our wellness sessions, feel free. You can text that number or call it. It will come directly to our phone. So you have full access to us.
And then, of course, if you're in the DC, Maryland, or Virginia area in DC, you can give us a call for LimbsNThings, LimbsNThings.com. You can call us at 202-643-2636, or you can send us an email at LimbsNThings@gmail.com. We serve aging adults. And we also accept Medicare, TRICARE, and commercial insurances as your secondary payer. Do you guys accept insurance?
We don't. We are out of network. We are a cash-based PT. But we do provide super bills for individuals. So those who are out of network, because we are out of network, some insurance that was like, okay, you can get a super bill and they might reimburse you all the way, or they might say, hey, I might pay 50% of what they charge. So it just depends. But no, we haven't dived into the insurance. Yeah, we love in the out of network.
I do too. I'm out of network with all the others, so I totally understand. Yeah. So thank you again so much for joining us. I hope you have a wonderful Mother's Day, everybody.
Thank you. Happy Mother's Day, everybody.
Happy Mother's Day.
Thank you for having me.
No problem. I've enjoyed you. Thank you.
You're welcome. Have a good night.
You too. Bye-bye, everybody.